Hello, everybody. We are just waiting for a few minutes to start the webinar. We'll be starting shortly. I see some people are signing in. If you want to put in the chat where you're from, that would be great. We can find out where people are all signing in from. In just a few minutes, we will begin. All right, let's get started. We have about 25 people on here so far, and I think people are coming on slowly. So I'd just like to introduce some of the members that are here right now. My name is Josephine Grima, and I am the Chief Science Officer of the Foundation. We have Deborah Goodman here, who is also a member of our staff and works a lot with our events. And I'd like to begin with introducing Dr. Michael Weimer, who will introduce one of our presenters now, too.
Thank you very much. Good morning, everybody. I actually wanted to come by and say hello this morning. Number of reasons. First and foremost, we have two extraordinary presenters today, Dr. Shekar and Dr. Coselli. And Brigham and Women's Hospital, the home of Dr. Shekar, has been a wonderful sponsor of this event, one of our presenting sponsors. And events like this only happen because of great friends and great institutions. So Dr. Shekar, thank you for that. Also, I'd like to mention Joe Coselli. Dr. Coselli is, as you know, also a wonderful surgeon, major supporter, past honoree, a member of our PAB, and a good friend of the foundation. So those of you joining this morning are in for a wonderful educational experience. The other thing I'd like to just talk momentarily about is the power of E3. So I looked this morning, and as of this morning, we have over 2,600 registrants. And those registrants come from 74 countries. Pretty crazy when you think about it. You know, when we do our annual conferences, we usually have around 400 adult registrants for a conference. And so you can see the power of technology and the power of reaching out. This is also the largest event in the history of the foundation. We have 94 speakers. We also have over 300 health professionals that have signed up to participate, along with members of the Marfan, loeys-dietz, beds movement, and other communities. So thank you from the bottom of our hearts. I hope you enjoy today's presentation. And with that, I'll turn it back to Joe. Thank you.
Okay. I just want to let the audience know that I just got a note that Dr. Coselli is in surgery and unfortunately will not be able to make this webinar. So, but we do have Dr. Shekar here, so that will be great. I'm sure that he can answer many of the questions that will be put forth. And let's continue. So again, we wanted to thank our sponsors. You know, Dr. Shekar is from Brigham and Women's Hospital and is a great supporter of the foundation and a great, has a wonderful clinic up in Boston and was going to host our in-person conference this year, but instead we are able to bring you this fabulous program virtually from that has turned into a global phenomenon, and we thank you very much. So I like to give Dr. Shekar an opportunity to say hello to the audience.
Yeah, thank you, Joe. And good afternoon to you all. I think we just passed the noon mark here. So good afternoon to you all. It's an honor and a privilege to be here virtually speaking to all of you. And I would like to specifically thank Joe and the National Marfan Foundation for honoring me with this opportunity. The Brigham and Women's Hospital is happy to sponsor this event, and this is an exciting event occurring in the COVID times on a virtual platform, and it's very nice to see the response it has received. And you know, I look forward to an engaging discussion. It is I'm sorry that Dr. Coselli couldn't attend, but he's doing better things. He's saving somebody's life, as he has done for the last so many years. And I guess I'll be flying solo, and I will try to do justice from all sides. But I presume you will be showing Dr. Coselli's video as well. Yeah, that'll be great.
Yes.
So I look forward to a discussion following the video presentation. Thank you once again.
Okay, thank you. So just as a note before we start, I want to let everybody know that the International E3 Summit is a forum to provide an open discussion of issues related to genetic aortic and vascular conditions. The opinions stated in each of the talks are those of the speakers and not necessarily those of the Marfan Foundation or VASCERN. And if you need any kind of clarifications, you can always send us an email at marfan.org/E3ask. Okay, and so we're going to go and start the videos. So if everybody can undo their camera and go on mute.
Greetings. My name is Prem Shekar. I'm a cardiac surgeon at the Brigham and Women's Hospital in Boston, Massachusetts. I am an associate professor of surgery at the Harvard Medical School. It is a great pleasure to be here with you all today, along with Dr. Joseph Coselli, to talk about cardiac surgery in connective tissue disease, particularly Marfan's and loeys-dietz syndrome. I am very grateful to the organizers and the leadership of the National Marfan Foundation for allowing me the opportunity to speak today and participate in this symposium along with my esteemed colleague, Dr. Joseph Coselli. We have divided the topic amongst ourselves. I will speak about surgery of the aortic root and ascending aorta. Dr. Coselli will focus on surgery of the thoracoabdominal aorta. The most common operation that is done in patients who have Marfan's and loeys-dietz syndrome is called the aortic valve sparing aortic root replacement procedure. This operation is done for patients who have an aortic root aneurysm but have a normally functioning aortic valve or an aortic valve that is malfunctioning because of an expanding aneurysm. In any case, the aortic valve is potentially normal from an anatomic standpoint and hence can be preserved. This is in contrast to doing an aortic root replacement using a mechanical or a biological prosthesis. This operation is done under general anesthesia through an incision called a midline sternotomy, which runs up and down the front of your chest. This operation takes anywhere up to 5 hours to complete. Subsequent to the operation, the patient usually goes to the intensive care unit for a day or two and subsequently to a step-down unit for the next 2 to 3 days before being discharged. Given that the average age of the population of patients with this condition is very young, a quick recovery is anticipated. In the postoperative period, at home, there will be some restrictions for the first 8 to 10 weeks. This would include no driving, no heavy lifting, and also abstaining from activities at school, college, or work. In an otherwise healthy patient, the risk of this operation should be no greater than 1% for risk of death and 1% for risk of major complications. The next kind of operation that is done for patients with Marfan syndrome, either in conjunction with the aortic root procedure or other procedures, is the replacement of the ascending aorta or the aortic arch for an aneurysm in this area. This is done based on size, and we can discuss that in more detail if there are specific questions. The replacement of the ascending and arch of the aorta is also done through a similar incision called the midline sternotomy. It involves the heart-lung machine and stopping of the heart. as does the aortic root procedure as well. In addition, aortic arch and ascending aortic surgery may involve deep hypothermic circulatory arrest, which is a process by which the blood temperature is cooled down to anywhere between 18 degrees Celsius to 25 degrees Celsius in order to facilitate a bloodless field when we are doing complex surgery in the area of the arteries that supply blood to your brain. If the process includes deep hypothermic circulatory arrest, the operation is also about 4 to 5 hours long, and the recovery is more or less the same. However, when an aortic root operation is combined with an aortic or arch procedure, the operation could be longer than 6 hours. The third kind of operation that is done in patients with Marfan syndrome is a mitral valve procedure. It is not uncommon for patients with connective tissue disease to have problems with their mitral valve causing mitral valve leakage or mitral regurgitation. The most common operation done for this is a mitral valve repair. In centers of excellence, the incidence of mitral valve repair in these patients could be as high as 90%, which means 90% of patients will have their valve successfully repaired. A repaired mitral valve is better than a replaced mitral valve as it confers additional benefits of function to the function of the heart and does not require the patient to be on any blood thinners in the long run. However, not all mitral valves can be repaired, and on occasion, mitral valves will need to be replaced. A detailed discussion about what kind of replacement prosthesis is appropriate for you is a discussion that you should have with your surgeon during the time of consultation, whether it relates to mitral valve disease or it relates to aortic root disease.
I'm Joe Coselli. I'm a cardiothoracic surgeon, cardiovascular surgeon, Baylor College of Medicine in Houston, Texas. I'm looking forward to contributing to this meeting for the Marfan Foundation and other organizations and bring to you some thoughts about the thoracic and thoracoabdominal aorta. Other presentations are going to address the more common surgery in patients with Marfan and connective tissue disorders involving the aortic valve, root, and ascending aorta. I'm going to talk about the arch and the aorta distal to that. First of all, I would like to comment that all of us, our hearts, our prayers, and our thoughts go out to all of the individuals, and especially those in the connective tissue communities who've been affected by COVID-19, those individuals themselves, their families, and their friends. We certainly wish them all well. So I'm going to talk to you about the surgery of the aorta and give you just some thoughts and overview, and hopefully it's more of a primer and a stimulus for questions and discussion than anything else. I'm going to talk about the arch and the thoracoabdominal aorta. We in Houston here have taken a lot of pride in our relationship, particularly with the Marfan Foundation, where we've held these walks every summer for a number of years. You can see in these pictures that we have a very, very enthusiastic group, and it's been well attended. And from a financial standpoint, I hope it's been a nice contribution to the research efforts of these organizations. These are a few disclosures that I might have. None of them really are directly related to what I'm going to present to you, but I thought I would put them in there for completeness' sake. I know the audience is varied. We've got a lot of families, patients, and friends of those individuals. And so that in a general way, although it's maybe somewhat of a duplication of other information that you've had or may have, but just in a way of review, the proximal aorta is the aortic valve, root, and ascending aorta. And then there's the transverse aortic arch, which is the upper portion from which the brachiocephalic vessels arise, those that go to the brain, right and left, as well as the right and left arms. The descending thoracic aorta is that portion which extends from the arch down to the diaphragm, and the abdominal portion is from the diaphragm down. And typical infrarenal abdominal aortic aneurysms are that very last portion below the arteries that goes to the kidneys. The thoracoabdominal aorta is the combined segments of the descending thoracic and the abdominal aorta. The proximal aorta is made up of the transverse aortic arch as well as the ascending aorta and the root. And the distal aorta is the thoracoabdominal aorta, the combined descending thoracic and abdominal components. The approach to these various segments are quite different. When we approach the proximal aorta, we do that through a median sternotomy, and the distal aorta is approached either through a descending thoracic or a thoracoabdominal aorta. I'll show you those hopefully here in a second. We operate on these problems certainly in all patients who are symptomatic. They should have repairs and repairs done urgently, regardless of the section or the portion of the aorta that's involved. And more elective repairs in patients who are asymptomatic, and this is the majority of patients, we generally recommend operation if there's a yearly growth of greater than 1/2 centimeter, and some of the sizes that you see on this slide. These are based on guidelines for thoracic aortic disease from Circulation in 2010. And by and large, for the proximal aorta, it's about 5.5 centimeters. But in patients with Marfan syndrome, it's more in the 5 centimeter range. And for loeys-dietz syndrome, it's more in the 4 to 4.5 range. For the descending thoracic aorta, with and without dissection, it's around 5.5 centimeters to 6 centimeters, and for the thoracoabdominal aorta, around 6 centimeters in diameter. To give you kind of a reference point, 6 centimeters is about the diameter of a Coke or a Pepsi can. So size does make a difference, rate of growth does make a difference, and whether or not a patient is symptomatic or asymptomatic does make a difference. The most common situation in the distal aorta that we operate upon in patients with an connective tissue disorder is actually secondary to aortic dissections, particularly in younger patients with, inherited thoracic aortic disease. In the non-inherited disease, it's generally a fusiform aneurysm and is more common in patients who are older, patients in their late 60s, 70s, and 80s. So dissection is one of the problems which we encounter with increased and frequency in patients with connective tissue disorders. And we break these things down into various categorizations. This is based primarily on extent, and we have two classifications. One is the DeBakey classification, and one is the Stanford classification. So if you look at this, the first one on the left, that's a DeBakey type 2 aortic dissection or a Stanford A because it involves the proximal aorta and the proximal aorta open. This is an emergency operation pretty much in all situations. Medical management with blood pressure control is primarily used in patients in the middle groin. The middle groin shows a DeBakey type 3 aortic dissection. So that's dissection distal to the branch vessels of the arch. And it's also referred to as a Stanford type B dissection. On the right is a Stanford type A dissection, but it involves all of the aorta, ascending as well as the thoracoabdominal. And it's also referred to as a DeBakey type 1 dissection. And it also requires an emergency repair like the one on the far left. This is what dissections look like. An acute dissection you can see here on the left, where the wall between the true and the false lumen is that little wavy line in the green circle. When it looks like a curtain, it's frequently, rather more often than not, it's an acute dissection. When it's a straight line or a thick line, it's more like a door between the two lumens. When you have a dissection, it's a splitting of the wall so that you get a false channel and a true channel. So there's two separate channels. If it's thickened and more of a straight line, it's generally a chronic dissection. So emergency repair for the two on the left, type 1 dissection, type 2 dissection. The type 3 dissection on the far right is medical management. The two on the left are also Stanford A dissections, and the one on the right is a Stanford B dissection. As I mentioned, these proximal aortas are repaired through a median sternotomy, as you see here, and the thoracoabdominal aneurysms are approached through a thoracoabdominal incision with a patient on the left side. This is a cartoon repair of the thoracoabdominal aortic dissection, where all of the thoracoabdominal from the transverse aortic arch to the bifurcation is repaired. And the idea is to do an anatomic reconstruction with a Dacron graft, reattaching a number of important vessels, particularly those to the bowel and to the kidneys. We consider these complex aortic repairs when they involve the aortic arch, as you see in the diagram on the far left, and then the middle of the slide is a thoracoabdominal cartoon of a thoracoabdominal aortic aneurysm, which has been repaired with a Dacron graft. These have different challenges from a technical standpoint, not only the replacement of the aorta, but during the repair, the protection of the various organs which are at risk. And in the transverse aortic arch repair, the brain is particularly at risk because that's the arteries that go off to the brain, both the left and the right side. And then the thoracoabdominal repair, we're a bit more concerned about neurological issues involving the spinal cord, the kidneys, and of course the liver and other organs. The primary repair of the transverse aortic arch, whenever possible, is kept as simple as possible. And interestingly, the transverse aortic arch in patients, regardless of whether they have a connective tissue disorder, is kind of the least likely to be a problem. When you have a type A dissection, emergency operation, a Stanford type A dissection or a DeBakey type 2 or a type 1, if at all possible, we replace as little of the transverse aortic arch as possible in order to take a high-risk operation and keep it to a minimal amount of risk with a survival of the individual. And so we refer to this as a hemiarch, where we just replace the lesser curvature, the transverse aortic arch, that portion of the arch underneath the brachiocephalic vessels. In more complex aneurysms, which involve a dilatation of the transverse aortic arch, or when the tear destroys the transverse aortic arch, the entire transverse aortic arch has to be replaced. A reconstruction in the drawings and cartoons you see on the right-hand side is not uncommon. We'll use these branch grafts of the brachiocephalic vessels because they also become involved in the dissection and sometimes become aneurysmal. And the transverse aortic arch can be replaced in a number of ways. The two diagrams on the right can show where you're just doing the arch, but if you have concern about the remainder of the thoracoabdominal aorta, that lower drawing shows what we call an elephant trunk, a graft extending down into the descending thoracic aorta to be used later for reconstruction of the descending or thoracoabdominal aorta to simplify and lower the risk of the second operation. And these are some examples of this. These drawings in blue on the left-hand side are transverse aortic arch, where the ascending arch is done first. The elephant trunk you can see in the middle drawing, and then the reconstruction of the rest of the thoracoabdominal aorta is a second stage later, in a similar series with a debranching of the vessels of the transverse aortic arch on the right, and then the final reconstruction in the final diagram that you see out of these 6 drawings. It's the one on the farthest right-hand side. So what's new? We can place stent grafts in the descending thoracic aorta when we work on the arch. Then there's some hybrid operations that we can do, as well as what we call a frozen elephant trunk. Let's start with the first one. When we do that hemiarch repair that I described, in the middle drawing, you can see how there's the Dacron graft extends here in this purple circle underneath the lesser curvature. So this is the graft that we place in through the median sternotomy. We can drop a stent graft in the descending thoracic aorta that can be completely separate from this Dacron graft, and here it is shown on the drawing on the right-hand side. And this can be used to stabilize the descending thoracic aorta, or in patients who have a dissection, where the dissection compromises blood flow to the distal organs, liver, kidney, legs, etc., we can use this endovascular stent graft to open the true lumen and improve the perfusion distally. When used here, in some cases, what you see here on the far left-hand side is the arch has been replaced. We have an elephant trunk, and we have an aneurysm limited to the descending thoracic aorta with some relatively normal aorta here. In a patient who might be at increased risk for an open operation to replace this, we can run a wire from the femoral artery up into the elephant trunk and extend our repair down towards the level of the diaphragm, which would be about here where you see these branch vessels coming off. I want to talk a little bit about this with Marfan patients and connective tissue disorder. This is not always suitable because of the fact that you're replacing a device inside the aorta that has a sealing concept due to radial force. So it's not always appropriate for patients with Marfan syndrome, but it can tide us over to a more elective open operation at a later time. And in patients who are at high risk for an open operation, we can use these techniques to get the patient out of a difficult situation. In addition to slipping a stent graft in an open arch repair, we can actually replace the arch with a device that's here going to be available in the United States fairly soon. We've completed a clinical trial on it, but it's a device you can see here. It's got Dacron graft material here to replace the transverse aortic arch, but it's got a stent graft that's all one single piece that can be placed down to the descending thoracic aorta and then used to reattach the transverse aortic arch vessels and then replace the ascending aorta. It can be used with and without dissection. Again, endovascular stent grafts in patients with Marfan syndrome and other connective tissue disorders have to be used with caution. And this is what this looks like. This is arch repair here, and then the elephant trunk from the Thoraflex graft that I just showed you, and then bringing the patient back as a second operation and extending it down towards the diaphragm. You can see what this looks like here on the right-hand side with this X-ray. Again, in patients with Marfan syndrome, endovascular stent grafts have to be used with caution, but they are a tool that can be used in an emergency situation to salvage the immediate situation and bring the patient around to an elective procedure later. When it comes to the transverse aortic arch, Dr. Scott Lemaire and I edited and wrote this book on the transverse aortic arch. My team found that it was available on the internet and could be bought through Amazon, but at an extremely high price. When I look at that number, I wish I've only got 2 copies of this book. I wish I had a whole box full of them. So this is what this might look like. This is a chronic dissection of the thoracoabdominal aorta and the anatomic repair on the right. These thoracoabdominal repairs are nearly always related to chronic aortic dissection in patients with Marfan syndrome. And frequently, more frequently than in patients with non-Marfan syndrome, the entire thoracoabdominal aorta needs to be repaired. When we talk about thoracoabdominal aortic repair, we break it down into 4 extents. These are the Crawford extents. The ones that Marfan patients need the most is extent 2 from the transverse aortic arch all the way down to the aortic bifurcation. The experience in Marfan syndrome with these kind of repairs is actually quite good. This is a report from a number of series in the literature extending back to 2002 all the way to more recent studies in 16 and 17. And just the mortality rate is extremely, extremely low, as well as the risk of stroke, renal failure, and neurological problems with the spinal cord. This is from a report that we made a few years ago when we looked at a group of 127 thoracoabdominal patients with Marfan syndrome and distal aortic dissection. And you can see here in our own work with 127 patients that the mortality rate, the paraplegia rate, the renal failure rate, stroke rate were very, very low. We looked at 49 patients that we did consecutively with these long aneurysms of patients with Marfan syndrome, these extent 2 thoracoabdominal aneurysms. The mortality rate, stroke rate, and spinal cord problems were very, very low. But what we wanted to look at is also the quality of life of these individuals after they've had these extensive repairs. And what we found was that the quality of life from a physical component was not statistically lower than other individuals without Marfan syndrome, but it was slightly lower. But interestingly, because these patients are enthusiastic, they're knowledgeable, and they meet with organizations such as the Marfan Foundation, et cetera, they actually, in their quality of life surveys, had better mental components than the population in general. This is something I think we can all be very, very proud of. It is a problem for life if you have aortic pathology, if you have Marfan and connective tissue disorder. 70% of patients, in our experience, will need more than one operative repair if they go down that route. We looked at the spectrum of aortic operations in 300 patients with confirmed or suspected Marfan syndrome more than a decade ago. We've operated on many, many patients since then, but out of this particular group, almost 40% of the patients had at least 2 aortic operations over their lifetime, and a few of them had more than that. So again, when we look at what's new, we just want to remind everyone that the European position was and remains, as well as the US, that TEVAR is not recommended as the primary care in patients with connective tissue disorder, that an open operation is more definitive, but TEVAR can be used as a bailout in an emergency operation or as a bridge to definitive therapy in patients such as this. And this is would be an example of what I'm referring to. If you look at the cartoon on the right, we've taken a patient with a descending repair, extended it for a period of time, but then later this patient underwent a total endovascular repair. The remainder of the aorta, but prepared to do an open operation should be it'd be necessary. Most of these patients with connective tissue disorder have aortic dissections, and these total thoracoabdominal endovascular operations just haven't quite reached the mainstream, and none of them are actually right now currently approved by the FDA for use in any patient, much less in patients with connective tissue disorder. But these are on the horizon, and we think these are going to be an opportunity for a less invasive approach for virtually all patients with a thoracoabdominal aortic aneurysm. But this is in the future. It's something that's new, that's being worked on. We have a ways to go yet. We do have available to us, I mentioned earlier that patients with aortic dissection can have a malperfusion problem distally into the visceral and renal vessels. And we have some of these open endovascular stents which can help us open these vessels up and get us beyond an immediate life-threatening malperfusion problem and move to a more stable situation for long-term in later care. And this is what it looks like in drawings on the left and stent open wire stent grafts and dissection in the CT scans on the right. This is a device that's currently FDA approved by Cook. And one final comment, occasionally when we reattach, particularly in patients with connective tissue disorders, we'll develop these patch aneurysms of the intercostal arteries. Never fear, we've operated on a number of these individuals with endovascular stent grafts. And this is an area where endovascular stent grafts absolutely in patients with connective tissue disorder just can be useful, where we've taken these pseudoaneurysms where the intercostal arteries have been reattached. We can go back in with a stent graft and cover those up. As you can see here, the aneurysm sealed off. And when we use CSF drainage and manage the blood pressure properly, we have yet, and quite a number of these cases, have had an incidence with neurological deficit problems. So I want to thank everyone for their attention, the opportunity to share some of this information with you, and hopefully it stimulates questions that can bring about a very interesting and profitable discussion. And I want to congratulate everyone in my team that's contributed so much to this work over the years. You can see in one of our last meetings here, with the Marfan walk here in Houston during the summer, that we've got an enthusiastic group of individuals dedicated to the efforts of the things I've showed you. Thank you very much.
That was a lot of information there, and very, very detailed. So let's see if we can tackle some of these questions. I think many of them were answered in both presentations, but maybe it goes a little bit fast for our membership, so maybe we can just go over some. And let me bring that up. Okie dokie. So, at what measurement should someone with Marfan have a AAA repair? And I think I saw on Dr. Coselli's slide that it indicated that something 6 centimeters or over was the size for surgery, or if it's asymptomatic, if it's symptomatic, you have to have it like immediately. So do you want to comment on that, Dr. Shekar?
Sure. So, I mean, conventionally for us medical folk, when you say AAA repair, we automatically default to assuming that you are asking a question about an abdominal aortic aneurysm.
Mm-hmm.
But I have seen on occasion that the word AAA has also been used for ascending aortic aneurysm as well, and that's usually not the medical reference. So, and Joe, you are absolutely right that in an abdominal aortic aneurysm, usually upwards of 5, closer to 6 is where we recommend surgery. And of course, like Joe said, somebody who's had a rapid increase in size. Whereas come to the aortic root or the ascending thoracic aorta, we start to recommend surgery at 5.0 centimeters for patients with Marfan syndrome. And for loeys-dietz, the bar is a little bit lower at 4.5 centimeters. And again, once again, over here as well, it's the rate of growth. If there is a sudden accelerated growth, then that's an indication for surgery, irrespective of absolute size. Having said that, I would like to make one important comment, is that for all patients, if there is a family history of aortic catastrophe, as in if there is a member in your family who has Marfan's, who had a dissection or had a rupture or sudden death at a certain size, and that automatically becomes the size at which you should have your aneurysm corrected. So we see sometimes people with Marfan come to us with the story that, granddad or uncle or dad passed away with a aortic root of 4.5. So it doesn't matter that the number for conventional indication is 5.0. If something happened to somebody in your family at 4.5, then 4.5 is your number.
Okay, thank you. That's very important, that everybody has to be consider their family history, and that should be determined with your personal physician and knowing what has happened in your family. Okay, so the second question here are, what are the warning symptoms of an aortic abdominal aneurysm? She says that she's had the rest of her aorta replaced and severe back pains were her warning signs. And how much higher of a risk is it to have that kind of surgery compared to the rest of the aorta?
So more often than not, abdominal aortic aneurysms are incidentally picked up on abdominal examinations or ultrasound examinations. But occasionally, in somebody who is really skinny, you can actually see an abdominal aortic aneurysm pulsate. Secondly, people could have a dull aching pain, and that could be the manifestation of an abdominal aneurysm. The surgery for the abdominal aortic aneurysm, when compared to surgery of the aortic root or the aortic arch or the thoracic and upper abdominal aorta, is much lower. It is just the abdominal aorta is a relatively straightforward procedure compared to what you've had done before.
Okay, great. So I guess, much of this has been covered during the talk about what the current recommendations are for when to do surgery for root, transverse, and descending aortic aneurysms. It was one slide that was up there that had all of the sizes. Maybe you want to just go over that briefly again?
Yes. So for absolute sizes, for the aortic root and ascending thoracic aorta, Marfan's 5.0, loeys-dietz 4.5. And for the transverse aortic arch, it is 5. And as you go further down into the descending thoracic aorta, it is between 5 and 6 for absolute numbers. But then again, there comes the additional caveat of rate of increase in size. So on a yearly or a 6-monthly MRI or CT, if there is a rapid increase in size, then that's an indication that the biology of this aneurysm has changed.
Mm-hmm.
And again, like I mentioned before, a family history of aortic disease is particularly important as well.
Great, thank you. So this is a question that we get very often. Am I at a greater risk of thoracic or abdominal aortic aneurysms or dissections if I have a family history? And as we just said, that is certainly the case. You do have to look at your family history. But is there any increase in risk even of getting an abdominal aneurysm after you've had the aortic root and maybe arch repaired?
I lost your final comment there, Joe.
So is having your aortic root and your ascending arch repaired, does that actually cause an increase in your chances of having aneurysms in your descending aorta?
No, the fact that you had an aortic root procedure or an ascending procedure does not increase the chance that you would have an arch or a thoracoabdominal aneurysm or dissection. I think the fact that you had one intervention doesn't mean something else will pop up. But the answer to the question of am I at a greater risk of aneurysm or dissections if I have a family history of these events, the answer to that is yes, because if you have a genetic tree that shows you are prone to a vascular problem, which is aneurysm or dissection, then it tends to be true.
Mm-hmm. Okay.
And particularly at certain sizes.
All right. Okay, so this question was asked by Susan, and she says, I've asked this several times, but haven't been able to get an answer. So what is the incidence of aortic dissection type A versus type B in Marfan patients who are diagnosed and followed? I know several people, including myself, who have dissected despite being closely monitored. We all dissected well below the surgical threshold. What % of Marfan patients experience this?
I think I cannot answer that precisely, but I can tell you that the incidence of an aortic dissection is about 2 or 3 per 100,000 population. That is the incidence of aortic dissection. And the most common people that have an aortic dissection are people who have hypertension and do not have connective tissue disease. The next most common group of people that have aortic dissections are people with connective tissue disease. So if you take a cohort of people that have dissections, people with connective tissue disease are relatively lower in that big pool. But if you take a pool, isolated pool of connective tissue disease, then yes, you're you're at a higher risk of having a dissection because the connective tissue is weak. I don't believe I have off the cuff an actual number for the incidence of aortic dissection, and I can come back and follow up with you on that, Joe, and give you some precise information. And it is true. It is true that you don't necessarily have to have an aneurysm of your aorta in order for you to dissect. You can have patients with connective tissue disease who will dissect at relatively normal sizes. And that's just the nature of the biology of the condition. Actually, in fact, just yesterday, I admitted a patient to the hospital in who I had done an aortic root procedure about 12 years ago and developed a type B dissection. And the aorta was 2.7 centimeters. So it occurred at normal size, and that can happen. But it will happen at a higher frequency if you have an aneurysm.
Okay.
Does that make sense? Yeah.
Yes. Okay. Thank you. So this is another question asked by Timo, and maybe we also maybe need to look at some papers explaining this, and maybe we can come back to it, but let's just go over the question. So if you have 100 people who suffered aortic dissections, how many of these statistically have the diagnosis of Marfan, VEDS, loeys-dietz, or BAV, or FAATD? Is there any good scientific paper explaining what disease causes the aorta to fail in numbers per such disease out of a population of all who have aortic disease? And I think you alluded that in your answer before about that it is common in the general population, and they're usually older people. But maybe you want to comment more here, and we can look for some papers to answer this question later on.
Right. I think, if you have Marfan and, the vascular EDS or loeys-dietz, you are the next in line in terms of the people afflicted by aortic dissections. And I will gather some data from the International Registry for Aortic Disease about the accurate numbers. But bicuspid aortic valves are sort of number 3 on the list. So number 1 on the list, like I said, and like you alluded to, Joe, is older patients or even younger patients with uncontrolled hypertension and atherosclerotic aortas. They tend to dissect the most. And of course, the Marfans and vascular connective tissue disorders come next.
Okay, great. So this one is sent in by Alexis. Does having a descending aortic dissection that was repaired with a Dacron graft put me at a greater risk of having a future ascending aortic dissection?
Short answer is no. No. The fact that you had a dissection in one location that was successfully repaired doesn't mean you're at a higher risk of having an ascending aortic dissection. But what it does mean is that your ascending aorta and indeed the abdominal aorta has to be very closely surveilled and followed over time.
So the next question is, are there additional symptoms to watch for? Smaller size of aneurysm for potential dissection, surgery or with aneurysm in the sinus of Valsalva plus bicuspid aortic valve?
I would assume this question probably relates to a sinus of Valsalva aneurysm. The only other additional symptom that one could look out for in a known sinus of Valsalva aneurysm is that as the sinus of Valsalva aneurysm grows, it tends to make the aortic valve incompetent, as in the aortic valve no longer closes properly and the valve starts to leak. And when that happens, shortness of breath is a symptom that appears due to a leaky aortic valve. But aside from that, most of these aneurysms, as remain fairly quiet for an extended period of time until they get to a certain size where they may produce a dull pain.
And how about, having the bicuspid aortic valve? Is that something that can be saved, or do you have to get a different valve if you have a BAV with a sinus of Valsalva aneurysm?
Yeah, one of the, the bicuspid aortic valve with aortic root or ascending aortic aneurysm disease is a known combination. And more frequently, we have people have a bicuspid valve with a normal root, but a ascending aortic aneurysm where the operation is just to replace it with a tube graft. But in patients who have bicuspid valve, which is structurally normal and functionally normal, but they have a root aneurysm, you can do an aortic valve sparing aortic root replacement procedure. So even a bicuspid valve that is anatomically normal, has no calcium or other degeneration, is still better preserved than giving the patient a mechanical or a biological valve. So we do offer valve sparing surgery for bicuspid valves as well.
Okay, that's great to know. So this is by Roberta. Can you explain the problem with the upper abdominal aortic branches in Marfan syndrome and how this can be monitored and or treated?
Well, the upper abdominal aortic branches are the arteries that supply blood to your gut. There's two of them, and there are two arteries that supply blood to your right and left kidney, and that's what we refer to as the visceral segment. There's no actual problem with these branches themselves, aside from the fact that a thoracoabdominal aneurysm type 2 or Crawford type 2 or type 3, as Dr. Coselli showed in his slides, that can affect this location. And in replacing the aneurysm of a thoracoabdominal aorta, we have to take great care to appropriately relocate these branches onto that graft and ensure that the blood supply to these organs are preserved. Secondly, aortic dissections sometimes, in an aortic dissection, a single barrel aorta is converted then into a double barrel aorta. And sometimes the abdominal aortic branches, some of them can come off what we call the true lumen, and some of them can come off the false lumen, and that sort of poses unique technical challenges when we surgically correct for the condition. So those are the two comments I would make for that.
Okay, great. I think we asked that. Can you comment on paralysis after aortic repair for Class B dissection with abdominal aneurysm? And what complications have you seen after aortic abdominal thoracic repair if you have severe scoliosis?
Right. Paralysis, I presume we are talking about paraplegia, where the loss of power of your legs. And And again, it's not doesn't really happen with an abdominal aneurysm, but more happens with a thoracic or thoracoabdominal aneurysm or dissection.
Mhm.
And in the past, the risk of paraplegia was very high, and it was almost close to 20%, in the days gone by. But nowadays, the risk of paraplegia is quite low. It's in the best centers, it is less than 5%. And as you saw, Dr. Coselli's experience, it was zero. And that is because we understand the blood supply to the spinal cord much better, and there are so many advanced techniques that are used, starting from something as simple as a spinal drain, which they put a little catheter that goes around your spinal cord that helps maintain the pressure around your cord,
Mhm.
in addition to other advanced neurological testing that is done during the time of surgery to make sure that the blood supply to the spinal cord is well preserved. So there's a lot of equipment and science available today during the conduct of this operation that has really dramatically reduced the incidence of paraplegia after a thoracoabdominal surgery.
Mhm.
And there was a second part to that question, I think.
I think is
Scoliosis, yeah. It's aside from it being a technical challenge, because with scoliosis, the aorta also sort of moves with it and sometimes ends up on one side or the other. Other than being technically a little bit challenging, we've not really seen any particular complications because somebody had scoliosis.
Mhm. Mhm. Okay. The next question is asked by Susan. Is the heart-lung bypass required for descending aortic repair?
Yes, the short answer is yes, it is required. If we are going to do a replacement all the way from the subclavian artery, which is where the arch ends, then a complete bypass is required. But for other kinds of aneurysms along the descending thoracic aorta, we could use a partial heart-lung machine, which is called a left heart bypass. But yes, in both situations, we need to use the bypass machine so that we keep the lower side of the body perfused while we operate in a sequential fashion, doing the sewing at the top, and there's some sewing in the middle, and then some sewing at the bottom. And when we do that in a sequential manner, having the heart-lung machine is of great advantage to keep the legs and the kidneys and the bowel perfused during the operation.
Great. Okay. So this is an interesting question. Given the guidelines, would you operate on thoracic aorta with growth, for example, from a 3.5 to a 4.3 in 6 months, even though it's well below that 5.5 centimeter threshold?
Yes, absolutely. I mean, this fits into that thing that we said earlier about, it is a 8 millimeter growth over 6 months. So this is an accelerating aneurysm, which has not changed in its biology.
Right.
The only comment I would make over here is that we have to make sure that we are using the right test to make this diagnosis. Sometimes if you measure something with an echocardiogram at one time, and the next time you measure it with a CT scan or an MRI, that's apples and oranges. So you can have a lot of subjective error, particularly with echocardiograms. So I would suggest that if something like this happens, then we should confirm that it is indeed true, and a good diagnostic test for aneurysms is either an MRI or a CT scan.
Correct. Okay. All right. And even if one was done at one center compared to another, I think it's also very important for it to be read by the same center as well.
Correct.
Okay. let's look at this question. Given the much lower risk of TEVAR versus open surgery, why isn't this done as an initial repair for Marfan dissections, then repaired with an open surgery when they begin to fail? Would this not improve outcomes in the medium term? And I think Dr. Coselli had a little bit about this in his presentation. And I know the answer to this question, but you should comment on this as well, and why we feel that TEVAR is really not suitable for Marfan patients.
Right. I mean, like Joe mentioned in his presentation, the European and the U.S. scientific stance on TEVAR is that it is not appropriate for patients with connective tissue disease, because we do not believe that the science doesn't believe at this time that the radial force exerted by the TEVAR is well supported by the diseased connective tissue aorta. So that's why we don't offer that for patients with connective tissue disease. But Joe did mention that in patients with connective tissue disease who need an immediate bailout, we do the TEVAR in order to improve the blood supply and make the initial operation less complicated. But in the long run, we would have to go back and take out that TEVAR segment and replace it with a regular graft, because it's not a durable option in the long run. And like Joe said, there are certain patients who are extremely high risk for an open procedure, in which case the risk of doing a TEVAR is probably less, and therefore should be considered. But definitely not a primary option for patients who are otherwise stable and can undergo a regular operation with an acceptable level of risk.
Okay. Now we are coming up to our, it's already a little bit after 1. Let's see, these are the last 2 questions. So is the measurement for repair of a TAAA the same for LDS as it would be for Marfan? If not, what is it for LDS?
So I would presume that this is referring to an ascending aorta or aortic root, and the number is different. Marfan's syndrome, we recommend surgery at 5.0 or greater, and loeys-dietz syndrome, we recommend root replacement or ascending aortic replacement at 4.5 or greater, and sometimes even lower if there is a aortic story that happens at lower numbers. But for the abdominal aorta, so far we've not treated them differently. We've sort of treated them similarly.
Okay. And the one last question. If I have already had an aortic dissection and I develop an aneurysm in a new segment of my aorta, would that change the usual threshold for triggering surgery?
No, it does not. Each segment of the aorta has to be treated on its own merit, and they produce unique problems at distinct sizes, and therefore we cannot say that because you've had surgery in one location, we're going to wait a little bit longer on the other location, because the trouble that it causes in individual locations is extremely size dependent. So it's one factor in considering surgery, but each segment of the aorta has to be individually respected.
Right. Okay. Well, thank you so much for all of this excellent information, Dr. Shekar. This was really great. Appreciate all your help with this. And I just want to end this session by letting people know if they've had further questions or their questions wasn't answered, they can submit them through our website, which is marfan.org/E3ask. We would really like everybody to complete the survey session in the Hoover app so that we can learn how beneficial this was for you. We have an exhibitor section in the Hoover app with our virtual exhibit hall. Please visit the exhibitors. You can connect with your community through the app. There are many chats going on, meeting other people. Although this is being done virtually this year, it's a way to communicate and get to know other people. And if you are interested in sharing your experience on social media, we ask that you use the hashtag E3Summit20. And so I just want to end by saying thank you. Thank you for your time, Dr. Shekar. It's been a great pleasure to speak with you. We appreciate all the support you've given the foundation. And I'm sure our membership is extremely thankful to you as well.
It's my pleasure, Joe, and thank you for this opportunity. And I hope I was able to clarify a lot of the questions. And I know that I owe you some answers about some percentages, and I will get back to you on that so that you can share it with the community.
Okay, that sounds great. Thank you very much.
Bye now.
Bye-bye.